Hi, everyone. Today, I'm very excited to be speaking with Dr. Ramesh Singa. Dr. Singa is a board-certified anesthesiologist and pain management physician with the team at Republic Spine and Pain in Georgetown, Leander, and Austin, Texas. After he completed his undergrad and graduate studies at Johns Hopkins University and anesthesiology residency at RWJ Barnabas, he did his pain medicine fellowship at Rush University Medical Center. Dr. Singa then practiced interventional pain management and anesthesiology in California for 4 years. He and his wife soon came to their senses and moved to Texas in 2021, as did a lot of us. But if you're in Texas right now, especially in Austin, this freeze has been the big topic of the week, and it's caused a lot of trees to fall and a lot of electricity outages. So as we record this, we're in the middle of that freeze, and I'm hoping that everyone's safe and able to manage in this situation. But Dr. Singa, thank you for joining me, and look forward to talking about this important topic around pain and around long-haul COVID. So I wanted to jump into that, but thank you for joining me.
Thank you for hosting, and certainly education about these topics is really important for not only the public, but also for our colleagues.
Yeah,
so
absolutely.
I appreciate you, giving the time to talk about this.
Yeah, so I want to let's start with the long-haul COVID, and because that is kind of a big topic. It's a topic that obviously has dominated the healthcare world for the last couple of years as we've been in this pandemic and now coming out of it. But before, I think a lot of the topics that we were talking about were around COVID and its transmissibility and what are the best therapeutics and things like that. Whereas now it's changed to looking at what is, long-haul COVID, and people have had COVID now for a couple of years, and what type of symptoms that can linger on. So I'd love for you to speak a little bit about what we know now about long-haul COVID and what some of the science tells us.
Yeah, of course. No, thank you. So long-haul COVID is something that we now know is a byproduct of people who have been infected with COVID. They were tested via PCR, they had symptoms, and those symptoms still persist beyond about 12 weeks. And I first noticed it in our pain patients probably about a year ago, when a patient came in who was in his 30s, very healthy, no pain issues, and all of a sudden he started describing kind of tingling in his arms and legs, and all his imaging was negative, and he had no other health issues. Blood workup was negative as well for anything. So that's when I started really correlating COVID, his exposure to COVID, which had occurred only about 3 months prior, and he was not that sick, but nevertheless he still had COVID, and correlating it with the pain, because the most common long COVID symptoms people are probably aware of is fatigue, which happens in more than 50% of people who have had COVID and have fatigue during the time, headache, and attention disorder. So those are about 40% and about 25% found in those. So those are kind of well known, as well as a loss of smell, which can persist in probably about 10% of people with COVID who have that. So those are kind of more common. But the pain issues, when patients who are young and they show up and they have pain, we do a thorough workup of other things, because COVID is not always on our list, and nowadays with everybody vaccinated, people may not show symptoms as much. And so we do have patients who've come in with that nerve pain. Another patient came in, she was in her 60s, and she had worsening joint pain, her knee pain, her shoulder pain, hip pain, all of it was very severe. She couldn't even walk, or she put her vacation off because of that reason. So there is about 19% of people who have had COVID who have joint pain that's worsened. And again, all the workup is fairly negative for that. About 16% have chest discomfort, so that's non-cardiac, so not a heart attack or not thing dealing with their lungs, but this chest pain, non-cardiac chest discomfort. and then heel pain. So kind of people have heard about plantar fasciitis, things of that nature. But this heel pain suddenly flares up in folks who have COVID, and it's about 11% of people who have COVID have this heel pain. And so what we do, is actually treat it in the exact same way that we would treat if someone had knee pain due to arthritis of the knee joint, or if they had plantar fasciitis, or if they had costochondritis, which is inflammation of the rib cartilage that would cause chest discomfort. We would treat all those symptoms of pain from what we suspect is COVID via the same exact ways. So we do a steroid injection for the knee, or we do a nerve block for the ribs, or we would do a plantar fascia injection. So I suppose the main thing is we just have to be aware that these things can exist despite imaging being negative. And we would tell providers to don't dismiss patients just because they complain about something or describe something, as we would say it. And the workup initially seems like, well, maybe they're not really having this issue.
Right. And that's an important message that you just mentioned, where the imaging is negative, and we're saying that despite this, we still need to make sure that we, don't dismiss these patients, because these patients, especially the type of patients that complain of pain, can easily be dismissed, and oftentimes, can be called drug seeking and other things like that. So it's, very hard, I think, in your specialty to maintain that fine line between the patients that, to not dismiss the symptoms, but at the same time to be savvy enough to know as a practitioner, who really needs, who's maybe looking for medications versus who really is having a lot of symptoms. So very important message there. Now, you mentioned about how pain in different areas can get worse. Do we know whether one particular type of pain, like nerve pain, is worse with COVID, or is it more so that whoever has had a specific type of pain, their pain just exacerbates after COVID?
However, we do know the mechanism of COVID is a release of all these cytokines. And so based on that, I would say that most inflammatory diseases, which would include arthritis, would be worsened by this. As far as nerve pain being worse, I would say it's probably less likely, just because it's not like shingles where the virus is actually getting into the nerve bundle and causing pain in that fashion. But we don't know. I mean, it could be. Certainly people, like the patient who had the odd tingling in the arms and legs, and that certainly was nerve distribution and definitely seemed nerve related. But I would say at this point we don't know too much about, other than the cause of action, what the impact is. But with the millions and maybe billions of people infected with COVID, hopefully there'll be some research ongoing that will come up with some answers.
Yeah, and hopefully the research now continues to shift towards long-haul symptoms and especially pain, things like that. Now, you mentioned steroid injections, so I wanted to spend a few minutes talking about that and just your experience with steroid injections in general. I think that sometimes when patients have pain, there are various options, and some patients want certain natural approaches, and some patients maybe want to avoid medications. There's that mentality as well. Where do you see steroid injections in this whole situation in terms of how much benefit they could provide versus avoiding some of the side effects and things like that?
Oftentimes is helpful in more conservative care, such as physical therapy is not helpful or worsens pain, or if a patient has tried anti-inflammatories like ibuprofen or even prescription anti-inflammatories such as Celebrex, and more topical like Voltaren gel, and those have not been helpful, then we will start talking about using a steroid in a joint, for example, in order to reduce inflammation. And we will, by that time, time have done like an X-ray of the knee and seen that there is some degenerative changes, which would mean that there is inflammation in the joint, and so steroid dripping in the area would help. Oftentimes, patients will come into the clinic as a new patient and say, well, I had a cortisone injection, and there's a little bit of certainly question about where it went or what is it. And so I would want to state first that the cortisone is a steroid, and therefore when we talk about steroid injections, that we don't really use cortisone. We use a particular type of steroid that has been manufactured to mimic that. However, a cortisone injection is just a steroid, and a steroid can go anywhere. Some patients will go to their primary care and they will get a steroid injection in the buttock or the shoulder because that makes it go everywhere in the body, and generally patients get a steroid, they will feel better because it doesn't have a positive effect on their mood and on the body inflammation itself. And of course, it should be told that, as most of our colleagues, can attest, that we do produce steroid at a certain base level in general, and the steroid dose we give, especially as an injection, is pretty minimal and has really no long-lasting effect at all for patients. And so that's usually their biggest fear. Is one will say, well, if you give me a steroid injection, I'm going to gain weight. Am I going to start getting a hump on my back? Am I going to have diabetes? So I would say all that's pretty not likely. There was one study that showed that there was some impact on the bone density of women who were postmenopausal, but those women had gotten about 14 epidural injections. And so, that's a fairly large dose. We generally don't talk about the number of injections, which I know some providers will say, well, you shouldn't get more than 3 injections a year or 6 injections a year. It's really about the dose of steroid. And I always educate patients on, you will get a steroid, it'll go in a joint. Generally, we can give you about 6 injections of the type of steroid that we use, and it'll be safe to do that on an annual basis because the steroid is going to last, it'll go away, and then pretty much you're back to normal. So impact on their diabetes, for example, is usually a blood sugar elevation for a couple days, and it goes back to normal. And then as far as any weight gain, it's not going to happen. I mean, I usually will advise patients all the time that it's really oral steroids taken daily on a higher level is what's going to cause all these issues that you hear about associated with steroids. And I hope that our colleagues advise patients about this as well, because that's an important thing, because I think a lot of patients would benefit from steroid injections, wherever they do occur in their body. But I don't want them to have to worry about all these other things they hear about.
Yeah, I think the long-term oral steroids often get conflated with these injections, and so I think it's important for people to realize that they're two different things and certainly have two different effects. And we certainly worry about longer-term oral steroids in terms of side effects, just like you mentioned. So, and you were speaking about epidurals, so just wanted to ask you, because that is obviously a step up from a steroid injection. And so what are your thoughts around epidurals? I know you're trained as an anesthesiologist. You perform them. So can you tell the audience a little bit about epidurals in general?
Yeah, of course. So an epidural injection is a very specific type of injection that goes in a certain space, whether it's in the neck or the low back, into an area where the nerves do travel below. And so when we do an epidural injection using steroid, then we're injecting the steroid into the space so that it can calm down the nerves and decrease inflammation. This is the exact kind of epidural that women who are in labor receive. And in that situation, they get an epidural injection, but instead of steroid, there is a small little spaghetti wire put in their epidural space, which is like a little pipe. And that allows them to administer like the Novocaine to numb up their legs and their belly so they can go through labor with less discomfort. So it's done the exact same way. I usually will tell patients that with the epidural injections that we give, we're using steroid. We don't use Novocaine in ours because there's always a risk of falling, because therefore you won't get numb legs. But also we use X-ray guidance, which is a standard of care, to place it at a certain level. So the low back, whether it's L4, L5, which is the very lowest part of the lumbar spine, we use X-ray guidance. It takes about a minute. We're not feeling around in there, and our patients aren't pregnant, so they don't have like a hyper state where everything is going on. Obviously, when you're pregnant, it's a lot of worry things going on. So it's really quick, but it can be helpful for really only a particular subset of patients who have a certain disorder, and that's usually whether they have a disc herniation, which is the shock goes over the spine, and that can be touching a nerve, causing what is known as sciatic pain or radiculopathy, which is pain on the legs, or could be pain on the arms.
Right.
So that's what we use an epidural injection for that particular situations. So some patients will say, well, I had an epidural injection, and it turns out it was an injection in the knee. So not all injections are epidurals, but epidurals are all injections. So, but just to be clear, that and also epidural injections, they say, well, it'll work for the back pain, and I think we'll talk about this later, but not all epidurals will work because there may be other types of pain and other types of underlying issues causing the pain in the back. Right. And so the appropriate injection is necessary in order to relieve the pain.
Right.
So it's not a one-for-all injection will not help with pain.
Yeah. Now, shifting a little bit to some of the causes, because, pain is one of the most common complaints that people come in to see physicians for, and, you deal with that day in, day out. But when a patient comes in with, let's say, hip pain, we could take hip pain first, what are some of the most common things that you're seeing are contributing to hip pain in particular?
Joint degeneration is going to be the most prevalent. However, a couple other causes of hip pain are there as well. So we listen to the patient's history. So, for example, they say, well, my hip pain is worse when I stand up and put my weight on the leg. More likely it is that hip degeneration because the portion of the leg going into the socket is inflamed and the cartilage may be less, and so that's causing pain. And certain exam maneuvers that we can do in order to elicit it, and of course we'll do an X-ray, but pretty much we can tell by a simple exam finding whether it's truly a hip joint issue or not. Patients will also, however, have a normal hip joint, but they'll have what's called trochanteric bursitis, which is the cartilage area on the side of the leg, both sides, and so patients can kind of pinpoint, well, this is my pain right here on the side of my hip. And they'll talk about if they lie down while they're sleeping on that side, it'll be painful, so having to sleep on the other side. So that's bursitis. That's inflammation of the cartilage. It's where all the tendons attach from like the buttock muscle, like the gluteus, medius, and maximus. They attach to that side of the hip. And if that's inflamed, which usually can be just due to lying on that side all the time or excessive exercise, that can also resemble hip pain because it can radiate down or go from the hip down the side of the leg up to about the knee. And so it can easily resemble that. Some patients get it worse when they're walking. So I'll say, so it can easily mimic hip joint issues. But our exam, again, can elicit it. We generally don't do any imaging because you can base it on an exam, but that's definitely a cause. And then the third is sacroiliac joint issues. The sacroiliac joint is actually the largest joint in the body. It's the joint between the sacrum, the tailbone, and the hip joint. And so that creates a front part of a joint and a back part of a joint. So patients can have low back pain. They can have pain that radiates into the groin, that be caused by the front part of the joint. And then they have pain that kind of resembles hip pain. And so again, there's another 3 to 5 maneuvers we can use to gauge whether or not that's causing that pain or not. So of course, patients can have 1 or 2 of these in addition, or all 3 possibly, hopefully not. But those are the top 3 causes of hip pain.
And you guys kind of stand in between someone going, having hip pain and having their hip joint replaced. So, you're dealing early on, sometimes with advanced pain as well, but sometimes, trying to improve that pain so that they don't need to go towards a joint replacement, or that they can, prolong that as well. So, a very important role there. And then also, back pain is probably the most common, or one of the most common complaints that patients have. So what are you generally seeing as your main reasons for patients coming to you with back pain? It'll certainly be different from someone going to the primary, because you're obviously specialized. So you might be seeing more not the run-of-the-mill musculoskeletal issues, which you may be seeing some of those as well. But what are the main reasons for back pain that someone is coming in?
Main is arthritis of the spine joints.
Mm-hmm.
We actually do a lot more procedures for that than epidural injections, which, like we discussed earlier, was for the sciatic pain.
Yeah.
And that's because pretty much everyone's going to develop arthritis over time, as we live under Earth gravity, so it's been pushing down our spine.
Right.
And so these are the joints that are between each spine bone and allow us to twist and then forward and backwards. It's very common. And so patients will have worsened back pain, particularly when bending backwards or twisting. They'll come to us, we do an exam, we can easily palpate or press on these joints and can reproduce that pain. And the good thing about that treatment for that is, after physical therapy and core strengthening and anti-inflammatories, if they're not helpful, we do a two-stage injection. One is where we do what's called a medial branch block. Those are the nerves that come out of each joint. And those nerves go into the muscle, and that's when it causes pain.
Mm-hmm.
And spasm and, as you mentioned, musculoskeletal pain. So
right.
We actually block those nerves under live X-ray with Novocaine. And if there is pain relief, even for a couple of days, then we know that's the cause. And we can tell the insurance companies, we want to do what's called an ablation. And the ablation is where we go in and use heat in order to kind of stun the nerves so they don't transmit the pain. Usually for an average of a year. It could be 8 months, it could be 2 years, but an average of a year. And that process involves no steroid. And so safely do it for patients who don't have, who have diabetes or other comorbidities. So it's probably the most common procedure we've done, most common finding we have for patients.
Okay. Nice. Yeah, very important information. I know that you have to get back to your patients in a couple minutes. So what I want to ask you kind of in closing up is what, if someone was coming to you with pain, especially pain after COVID or different symptoms after COVID, one of which is pain, it could be fatigue, it could be a whole host of other symptoms. What is the main message to them, and what approach should they take for their pain?
Definitely follow up with, either us pain management or discuss with their primary or another physician they're seeing, because patients are often embarrassed to describe these symptoms when they're young, especially, or they don't want to be seen, as you said earlier, drug seeking, or they don't want to seem like they're crazy. And a few patients that actually mentioned that, they said, well, I didn't come in earlier because I thought I was crazy. So they themselves think that they are thinking of this thing is not real. So seeking out treatment is really important, because in some situations, with long COVID, it's not dangerous. It's not going to paralyze them. It's not going to cause any long-term harm in the sense that underlying structures can be repaired. But nevertheless, a lot of time, over 50% of patients with pain, there is depression. And I think about 70% of patients with long-term pain, there's anxiety.
Yeah.
So we definitely see patients who have both, and either that starts or it worsens.
Yeah.
We don't want to be in a situation where patients are not having relief and they're by themselves and having not only physical symptoms but mental symptoms as well.
Yeah.
So seek care.
Yeah. I mean, there's so much debilitating, effect of pain, with mental health, with loss of work, with, family situations, things like that. So important to address that. I'm glad you mentioned it because, conversations like this is intending to break down that stigma that we have around pain. So, a very important message to seek out care and good care. And I appreciate you coming on and talking about this, and I look forward to talking again.
Yeah, well, thank you so much for having me, and it was a great discussion, and I definitely look forward to being on it again.
Absolutely. Thanks.
All right, stay warm.